want to have better sound, you may want to grab a headset. We are very fortunate that we are going to listen to two wonderful orthodontists, two ladies, Morgane ACHOUCHE and Dr. Le Breton. They have a practice in Paris. They are pioneers in the use of Genius Gold, and they also do labial. Thank you, Leah. Hello, everybody. If you do not speak loud enough, do not hesitate to tell us. Well, first, we'd like to thank Charlie and the entire team. And they are very loyal. They invited us again to talk this year. I'm Dr. Le Breton. She is Dr. ACHOUCHE. We have a practice in Paris. We have a mixed practice. We do conventional orthodontics, but also lingual. And Morgane is going to start the presentation. Well, thank you very much, Charlie. Congratulations. I would like to congratulate the speakers who spoke before me because the quality of our presentation was great. I still do not see any gold brackets in your cases, and that's a shame because gold brackets are wonderful. And this is what we are going to talk about this morning. So I'm going to talk about osteosynthesis as a Genius Gold plus TARS. So first we're going to discuss the type of anchorage that we can have. We have the ALIX technique, and then you have the indirect technique with a TART. We will give an overview of all the indications, then we'll talk about the clinical aspects, and obviously we will present cases that Dr. Le Breton treated with Genius and also Genius Gold. So, how do you define this anchorage? The direct method, the ALIX technique, you have an osteosynthesis thread or wire, which is close and flush with the ramus, while the indirect technique, the osteosynthesis thread, is going to be around the head of the TAD. In all cases, the osteosynthesis screw is going to be what you are going to pull from, if you will. The technique was updated by Raphaël Philippi and Chloé Bernard. This is the ALIX technique that I'm discussing here when you have a direct anchorage. It's obviously, the name comes from Vitaly ALIX. He used to be an alpinist, and we gave the name to the technique. So it's named after ALIX. So you have a ramus here, and you have the same anchorage that you would have if you were an alpinist, but only we do that in the bone. The difference with the indirect technique, you see that the flap is quite small on the ramus. You insert the screw, and you do not need to have such a large flap that you have with conventional technique. Usually we apply this technique after we extract the wisdom teeth, and sometimes you need to extract the wisdom teeth and you take advantage of that to place this anchorage. Once the osteotomy is performed, you place the osteosynthesis wire, and then you are going to rotate the wire in order to be flush with the bone, and this is going to prevent any problems that you may have with the gingiva. Now, with the indirect technique, the osteosynthesis wire is going to be threaded around the head of the screw. Then we screw in the screw so that it becomes flush with the bone, and again you avoid any gingival irritation. Now, what are the indications for this impaction? Sometimes it's impossible to use it when you do not have enough room. 3 indications: when you have a discrepancy in vertical dimension, compensation of class 2 before surgery, and also compensation of class 3 when you do not do surgery. I just started a small study, only 32 cases, so I'm well aware that it's not enough. And the first thing you should know is that in my practice, I mostly use it in preparation for surgery in class 2 patients. In all indications, you really want to reduce the impact on the incisors. Well, in about 1/3 of the cases, okay, I'm going to rephrase that, says the speaker. So, in 30% of our cases, the incisor are not going to be proclined, and that's good. And we also reduce the treatment time. So it's, of course, an alternative treatment. So you do not extract. Therefore, treatment time is reduced because you do not have extraction. And in my hands, I think that you reduce the treatment time again when you have the compensation. So that's a biological benefit also when it comes to the leveling and alignment of the incisors, because you really reduce the proclination. So these are the different milestones. First, we bond the brackets. Then the surgeon is going to place the posterior anchorage while they extract the wisdom teeth. Usually this is performed under local anesthesia, so it's not really invasive. Then we activate the anchorage. This can be performed with night-tie springs or chains, and then we will remove the anchorage after the treatment is complete. So with the genius system, you do have the bonding of the genius system, extraction of wisdom teeth. You see that the distal part should really be inserted through on both sides of the ramus, so that the abalacrop is really flush with the bone. So this is an example of activation. You can use night-eye springs, and Dr. Le Breton will tell you more on protocol later in the presentation. The benefit of a abalacrop, well, sometimes a abalacrop become undone and they unbond, if you will. But as an orthodontist, we can, in case it becomes unthreaded, you can re-intervene. Well, sometimes you have a form of cantilever on the abalacrop, and in that case, the indirect technique with a smaller flap helps you very much in that you are not going to have the problem that I described before. And again, you can remove them without much pain. So this is when we remove. So those are the different steps. So after first we bond, we extract the wisdom teeth, we perform distalization, then we place the abalacrop, and then we activate with springs rather quickly in order to distalize, align, and avoid proclination of the incisors in the mandible. And then in the fourth step, you get the result that is very similar to surgical advancement. So this helps you correct the ACHOUCHE. Now I'm going to give the floor to my colleague for clinical cases. I'm going to show you 4 clinical cases. They are not complete. Some of those patients are still in treatment. I'm going to start with these patients. The reason why he came in, he wanted to level his teeth from a dental standpoint. A number of teeth are missing, 1/6, 1/4, 2/4. Periodontal situation is pretty much compromised. Also, 3/5 is missing. You can see that there's some serious growing. And in cases like those, well, I have a hard time saying, well, we should extract the premolars, right? There are already a number of teeth missing. I'd rather close spaces in order not to resort to too many implants. So when you have many teeth that have crowns that are missing, I have a hard time saying, well, I'm going to remove crowding by extracting teeth. So I try to keep as many teeth as possible. Now the site electron radiograph is just confirming what we see. There's some a level of deep bite, but the incisors are decently positioned. We do not want to procline the incisors. Pan X-ray is not so contributive. You do see that there's decay on 4-8. And so we decided to remove the crowding in the lower arch. We distalize the entire lower arch with a Balakov and we extract the wisdom teeth upper arch. I close the spaces that were occupied by 1-4 and 2-4, and well, the patients wanted to have an implant to replace 1-6, but eventually you will see later on that the patient didn't have the implant placed. Now, the Balakov is in situ. I decided to distalize with springs. I prefer springs. I think it's easier than a chain. I think that for patients it's more comfortable. You do not have to replace the chain. The only thing you can do is and change potentially is where you place the spring. I started on the premolars and then eventually the spring is now going to the canine, to the cuspid, and I find it really comfortable and easy to activate. This is the occlusal view. You see that the alignment unfolds very nicely and we get this distalization which helps with the removal of crowding. You see that there are some canine rotations. Do not hesitate to use a chain from 3 to 3 to reduce those rotations, but this is obviously something that you will manage during the finishing phase. At the end of treatment, you see that crowding has been removed. Periodontal tissues obviously have not been improved. Periodontal situation was already compromised. So this patient will need a maintenance program for periodontal regions. I think that in sector number 1, we will need to redo the crown, that the incisors are well leveled, and I think that we prevented proclination of the incisors, which was our objective in the first place. This is the final pan X-ray. You see that then we need to remove the TARDs. Side teleradiograph, you see that the mandible incisor axis remained the same. We corrected the deep bite, and I think that the roots are decently parallel. Second clinical case, this was a preparation case before surgery. So ortho first, class 2, bilateral, midlines are shifted to the right. Tooth 4-7 is missing. 3-6 has a very extensive restoration, a lot of crowding. And in a case like that, I do not want to go for surgery and remove premolars in a patient with already so many missing teeth and restorations. So I wanted to distalize the teeth in the mandible with anchorage. Side teleradiograph confirm the class 2. The incisor is proclined. I do not want to increase proclination. It would be even better if we could retrocline them slightly. So pan X-ray is not highly contributive. And so for this patient, I decided to correct crowding by distalization on abalakovs, and you see that there are no wisdom teeth to remove, and it's even, well, of course it's better if you extract wisdom teeth. So if they have the wisdom teeth, sometimes they want to extract them before they go for orthodontic treatment. The best option is to do both at the same time, kill 2 birds with 1 stone. So you extract the wisdom teeth and you place the Balakov. That way you also benefit from the bone remodeling after extraction. Now, you continue with screws and springs. I started the springs on 4-4, and then I moved from the molars to the canines. So treatment is still ongoing, and this is a treatment option which helps avoid surgery. And again, you do not have to extract premolars. Now, those are complex cases, and we try to provide the best possible treatment to our patients. Now, this is a difficult clinical case. The case was not that difficult, but the patient is difficult. You know, in Paris, we have difficult patients. This gentleman came in because he had headaches. He had a bad pain as well in the back. And the medical doctor said, well, may come from the teeth. When he comes in, the situation is not too bad. Class 1, bilateral, slight crowding, but the side teleradiograph will demonstrate that there's a class 2, there's a compensation of this class 2, skeletal class 2, but it's dental class 1. So I decided to propose this treatment option. So this is the front x-ray. This patient has wisdom teeth, and you know that you're going to leverage the fact that you extract the wisdom teeth to decompensate class 2. So I got the authorization from the osteopath, from the physio, and I accepted to treat him to try and potentially alleviate the pain that he had in the back and in the neck. So I used a Balakov. The Balakovs, I think, are interesting when you have borderline cases. If you do not extract premolars, I think that the treatment is less risky. And so I didn't feel. I thought, well, it's better to extract the wisdom teeth than extracting premolars. So the surgeon extracts the wisdom teeth, places the Balakov. This is the day when we bonded and replaced the heart. Obviously, you see that the incisors are not bonded at the mandible because it's worthwhile. It's not. I mean, it doesn't make sense to do a back and forth movement. So I start with the canines, and then eventually I will bond on the incisors, and I will level the case. Now, this is so much I prepared the case, is decompensated, and you see that everything is leveled. This is the pan X-ray, very nice retrusion, side teleradiograph before surgery, because again we prepared that gentleman for surgery. So now there's a nice repositioning, decompensation. We were able to take advantage of the space that we gained with extracting the wisdom teeth to retrocline slightly the incisors. When the patient went for surgery, you see that those are the radiograph after surgery. We are currently still on treatment. We are doing the finishing. Now this is the pan X-ray, side teleradiograph, and you see the different milestones of treatment. So decompensation, surgery in the middle, and this is where we are to the far right. We are going to finish with this patient. This is a case that we completed, a young boy from Paris. He didn't like his lip line. There's almost a lip incompetency. And so I didn't want to treat that patient. However, there was a cross bite at the level of tooth number 17, so I accepted to treat him. The slight crowding at the lower arch is a class 2, skeletal class 2, and it has all signs of a conventional compensation of skeletal class 2. The 8s are present, so we are going again to kill two birds with one stone. We're going to extract the wisdom teeth, we're going to distalize the entire arch with the Balakovs, and we're going to perform a genioplasty plus mandibular advancement. So again, I'm using the same springs, a chain from 4 to 4 to avoid spaces to become open again. So we're maintaining the space closed. This is the post-Balakov placement radiograph, and this is before surgery. So the ortho phase is complete. Class 2 is decompensated. Incisors are properly straightened. This is the side teleradiograph, which shows that the mandible incisors are properly positioned in the socket. Nothing to mention on the pan X-ray. This is immediately at the end of the treatment. Before surgery, now we have a bilateral class 1. 1/7 is corrected, the patient's happy. Those are the occlusion view. Pan X-ray at the end of treatment after surgery. And I would like to show you the side teleradiograph after surgery. Now, those are the different milestones. You do see the different steps. So, ortho decompensation with a Balakov, extraction of wisdom teeth, then surgery in the middle, and end of treatment to the right. So, this really to demonstrate and potentially open treatment avenues. And with this Balakov technique, I think you can avoid premolar extractions. It shortens treatment time, gives other options, and I'm under the impression that it's less invasive in a way than premolar extractions. Now I'm going to give the floor to my colleague for conclusions.
Don't forget it's a local anesthesia in most of the times. The biological cost is not only lower, we have almost no issues when there is a thin biotype and a very weak periodontal tissue, no periodontal issues. And moreover, the treatment is optimized because the treatment time is relatively long. So we reduce by 1/3 the treatment time during the leveling and alignment phase. And it's more adapted to the Genius system because it's a passive system. There's a good control of the incisors phase. Thank you very much for your attention. Thank you very much. Perfect timing. Thank you for the presentation. Anyone has a question? I have a question. Even with the 0.14, you can start distalizing, pushing backwards. Okay. You can start with a 0.14. On the premolars, it doesn't pull that much. There's not so much traction, so you can then move on to the cuspids. We did not observe any specific issues to start pulling on the 0.14. Go ahead. Thank you very much. It was very elegant. It's a very elegant way. Decompensation is sometimes not enough on class 2s. And with the posterior traction, the ACHOUCHE mini screw is not always an easy way to deal with the problem. So it's easy to remove the system. I really think it's elegant. Congratulations. And also what I wanted to say, and that is an advice for case number 3. You remember that patient who was a bit of a pain in the neck? Surgery when there is pain. Wait, no. You do surgery because he doesn't like his profile, but not because he's in pain. Careful with that. Because you never know when you're going to win. And if you only do surgery because he's got pain and he still has pain afterwards, you're in deep shit. So yes, you fix his profile, but you don't fix the pain. You don't know if you're going to fix the pain. So don't operate for pain. Don't do surgery for pain. Understand that he wants to change his profile and write that in the record. Write that you did the surgery because he wanted to improve the profile, not because the osteopath said he should come to you for surgery. Exactly. That's what happens with those patients. Be careful. Write it in the record. Write in the record that you're not doing surgery for the pain. You're doing surgery for the profile. Thank you very much for the presentation. I have a question. Why choose the Balakov technique rather than an endo-oral mini screw? Reproducibility. Where would you suggest to place the screw? Vertical 6 or 7? Korea, Latin America? So you don't require a maxillofacial surgeon. We don't do it.
Ça dépend s'il parle longtemps ou pas.
If I may, if I place a screw behind the 7, the cheeks are the obstacle. Cheeks are the obstacle. In 50% of the cases, you will not be able to use a screw. That's why I said your system was elegant. Because screws in that place, it's not always a good solution. Do you do it? Well, I've placed a few. Initially, I had trouble placing them because it used to slide, and a surgeon told me you should use a kind of a tool to go through the cortical, and then it's easier. No emergency, no patients who came to you for pain. Well, I haven't done hundreds. What I saw with the Balakov screws is that sometimes if you place them on a bone that is not quite mature enough, if there's not enough thickness, then the Balakov will go through. It's very operator dependent. But he's right to say that the bone maturation is important. Don't place an Balakov anchorage system on an immature bone. Now here we're talking about adults. If it was my child, I'd rather place it in cortical bone rather than the ramus. We can't do it. We wouldn't do it in Paris. Or you can ask a surgeon to do it. Here you have to remove the wisdom teeth. It's the same guy doing everything. It's a matter of habit. Who's the surgeon? I work with Aude Caillot, Dr. Bentini. Many surgeons do it. There's a learning curve. Once they placed one, and I had to extremity coming out, and I had to redo it and place a chain. Thank you for the beautiful presentation. What's the best way for posterior anchorage between the twisted ligature
and the spring?
And the spring. Here you have the little springs, one ring on one side, one ring on the other side, and you hook them. You sort of twist them in here. So you have a ligature on both sides. You have two arms. Yes, you do what you want. The ligature in the spring never breaks. It's never broken. You don't remove it, replace it, remove it, and replace it. You leave it. Once you place it, you leave it. Look here, there's glue on top. To fix the problem, because I already had the problem once. Now it's mostly reproducible. If I do it lingually, I ask them to twist it around and then go back. So the Balakov is twisted around and comes back. And I can hang on to it and place it lingually under the lingual bracket. There's no emergency for ligatures that will break. If I'm doing a night tie spring to distalize, then I can hook it on. But I don't do it myself because it happened to me once, and that just wasn't pleasant. I had a surgeon doing it for me, and the patient's cheek was injured. It depends where the head comes out. That's exactly that. Depends on where it comes out.